Good afternoon, everybody. On behalf of Science Integra, this is Dr. Pratik Tambe, Chairperson for the MOX Endocrinology Committee, welcoming you to today's afternoon session. We have an academic feast lined up for you, and we have some very eminent speakers and stalwarts in today's session. Thank you so much for joining in today. I'd also like to place on record our gratitude to Bharat Serums and Vaccines, who are the academic partners for today's event. They've done a lot of webinars in the past 2 to 3 months, and this is just yet another effort on their part in what is called as the Bridging Bharat initiative. Let me introduce the chairpersons for today's first session. Our first chairperson is none other than Dr. Nabanita Deka. She is the secretary of the Guwahati OBGYN Society, professor of obstetrics and gynecology at Deepu Medical College. She is the Obstetrics and Gynec Society Master Trainer for NCD, RKSK, EMOC, and PPIUCD. Been a speaker at AICOG several times, has multiple publications in national and international journals. And whenever I call her up and say, Madam, we would like to do a program in the past 2 years, she has never refused me. She is very forthcoming, always cooperative. And thanks to her, we've been able to reach out to the Northeast, and we've been able to talk to so many people and reach out to so many people who we normally would not be able to access because of the poor network and connectivity issues when we used to do physical CMEs. And now in pandemic, thanks to internet and thanks to our academic partners like Science Integra, like Bharat Serums, we are able to reach out to this entire region which was once neglected and we used to just ignore it. Can we have the next slide, please? Unfortunately, Professor Gokul Chandra Das, who is our past Vice President of FOXI, is unable to join us today because he has some commitments at the medical college, where Sir is the ex-professor and head. There is some meeting regarding examinations which is going on, which was scheduled very late, and Sir was informed regarding it quite late, and unfortunately, he is unable to join us today. He sent his best wishes to all the faculty, and I'm sure he will bless us. And unfortunately, we are unable to have him today, but we'll try and include him in one of the future programs that we conduct in this particular region. Next slide, please. Our third chairperson is Professor Dr. Girija Wagh. She is a professor at the Bharati Vidyapeeth University Medical College in Pune, consultant at Cloudline and Apollo Hospitals in Pune. She has her own hospital and fertility center in Kothurud, which is an area in Pune. Multiple awards, a glittering academic career, a very well sought after teacher for post graduation. She's been a member of the steering committee for the World Gestosis Organization. Last year, we had done the FOXI, ICOG, and Gestosis GCPR, that is the Good Clinical Practice Recommendations on Hypertensive Disorders in Pregnancy. And she was one of the key figures, along with Dr. Gorak Mandrupkar and several other leaders from India who brought together that particular guideline, which was published in November in Bhubaneswar. She is also the assistant coordinator for the National Eclampsia Registry, past chairperson for the Medical Disorders in Pregnancy Committee of FOXI, joint secretary of FOXI with Dr. Sanjay Gupta in 2010, and of course, she is a master trainer for Laksha and so many other government schemes which are rolled out to OBGYNs all over the country. Welcome, Dr. Girija Wagh, ma'am. And just as an aside, I would like to mention that madam is contesting for the post of Vice President of FOXI for the West Zone this year. And we wish her well in her attempt at continuing and furthering that journey in FOXI. Without further ado and taking too much time, I would like to request the chairpersons to start the ball rolling and introduce a very distinguished speaker for today, which is none other than our Vice Chairman of ICOG, Professor Dr. Lakshmi Shrikhande, and she'll be speaking on the role of low molecular weight heparins in recurrent pregnancy loss. But I don't want to take up too much time. I'd like to hand over to the chairpersons who will formally introduce our speaker and take the proceedings further. Thank you so much.
Hello.
Screen sharing, Pratik?
Yeah.
Yes, I, Dr. Nobonita Deka, I welcome you all to this session of webinar. I am very much thankful to Dr. Pratik Tambe, sure, because he has given us this opportunity. Yes, he has come to our place several times. Today, I am thankful to my co-chairperson Girija Wag ma'am, and today's speaker is none other than Lakshmi Shikhande ma'am. All of you know her well. She is a medical director, Shikhande Fertility Clinic, Nagpur, chairperson, designate ICOG 2020, past vice president ICOG, past senior vice president, patron and president of Vidarbha, sector of ISOPERB, received Nagpur Ratan Award at the hands of Union Minister Sri Nitin Gadkari ji, received Bharat Excellence Award for Women's Health, received Mero Dara Hanchotia Award for Best Committee of FOXY, past chairperson HIV and AIDS Committee FOXY, immediate past president of Menopause Society Nagpur, past president Nagpur OBG Society, visited 96 FOXY societies as invited faculty, delivered 11 orations and 450 guest lectures. She has publication 20 national and 11 international publications, sensitized 2 lakh adolescent boys and girls. We will be very happy to have her as a speaker. Welcome, ma'am.
Welcome, Dr. Lakshmi. It's going to be really a pleasure to listen to you. And Lakshmi comes from my part of the country, Navadita, from Nagpur. And I really feel honored from behalf of my area that you have invited such an eminent speaker for this particular symposium. Thank you so much. Lakshmi, you're not audible. Please unmute yourself. Yeah, we didn't hear you.
Yeah. Thank you, Dr. Deka and Girija, for your kind words. Good afternoon, friends. Today, my topic of deliberation is recurrent pregnancy loss. And in this presentation, Subbu, why it is not going forward?
Madam, just click once on the screen.
Yeah. In this presentation, I will be giving you all a comprehensive review about recurrent pregnancy loss. I will be covering the definition, incidence, etiology, evaluation, management, and at the end, I am giving summary and recommendations. So to introduce the subject, recurrent pregnancy loss is an emotionally traumatic experience which is similar to that associated with stillbirth or neonatal death. It is one of the most frustrating and difficult areas in reproductive medicine because the etiology is often unknown and there are few evidence-based diagnostic and treatment strategies. Studies on the etiology, evaluation and management of RPL are often flawed. And why it is so? Because more than one factor may exist in the same couple. There are lacunae in the literature. Because there are differences in the definitions, evaluation process. There is variations in treatment regimens even with the same drug. Randomized trials need to be very large to prove statistical and clinically significant differences. So with all these uncertainties, I will try to make the subject simple. Coming to the definition, it varies, which makes studying the phenomenon and determining which couples to counsel or treat more challenging for the clinicians. 2 or more failed clinical pregnancies as documented by ultrasonography or histopathological examination is taken as one definition, whereas other groups have taken the definition as 3 consecutive pregnancy losses which are not required to be intrauterine. There is no specific term for describing women who have had multiple spontaneous miscarriages interspersed with normal pregnancies. So when to start evaluation in these couples? In our practice, we start investigation after 2 failed clinical pregnancies, including biochemical pregnancies for women who has undergone IVF, non-visualized pregnancy losses, that is biochemical pregnancy losses, or pregnancies of unknown location, they have the same negative impact on future live birth as an intrauterine pregnancy losses, and that is why this has been included in the definition by some groups. RPL can be divided into primary or secondary. Primary refers to pregnancy loss in women who have never had a viable pregnancy. In contrast, secondary RPL refers to pregnancy loss in a woman who had a previous live birth. And obviously, the prognosis for successful pregnancy is better with secondary RPL. Approximately 15% of pregnant women, they experience sporadic loss of a clinically recognized pregnancy. Just 2% of pregnant women, they experience 2 consecutive pregnancy losses, and only 0.4 to 1%, they have 3 consecutive pregnancy losses. The prevalence of miscarriage is higher with increasing maternal age, and it is higher at very early gestational ages. If the gestational age is less than 6 weeks, the chances of miscarriage is 22 to 57%. It decreases to 15% at gestational age of 6 to 10 weeks, and it further decreases to 2 to 3% if the gestational age is 10 weeks or beyond. This is a slide from recent up-to-date 2020. You all can see that the maternal age plays a great role. If she is very young, 12 to 19, it is 13.3%, but from the age 20 onwards, the chances of miscarriage gradually increases, and if she is more than 45 years of age, chances of miscarriage increases to the tune of 93.4%. These couples, when they approach a clinician, they come to us with 2 major concerns. They want to know the cause and they want to know the risk of recurrence. Unfortunately, the cause of RPL can be determined in only 50% of patients. There are various etiological factors for recurrent pregnancy loss, including anatomic, immunological factors, genetic, endocrine, infections, thrombophilias, and environmental factors. Coming to them one by one in a very short manner. Acquired and congenital uterine abnormalities are responsible for 10 to 50% of RPL. The incidence of uterine anomalies in general population is 6.3%. In infertile women, it increases to 7.6%. And in women who are suffering from reproductive failure, this incidence increases to 16.1%. These are various uterine anomalies which can contribute to the causation of recurrent pregnancy loss, and the possible mechanism could be small cavity, which is less suitable areas for implantation. There can be vascular compromise. There can be a mechanical constraint of the space, and in some cases, cervical incompetence can also be a positive factor. For diagnosis of uterine anomalies, hysteroscopy with laparoscopy is the gold standard. Sonosalpingography and 3D ultrasound have more than 90% accuracy. Hysteroscopy is the only method which allows you a see and treat approach in the same sitting. Septate uterus is the uterine anomaly which is associated with the poorest reproductive outcome, and it is the most common uterine abnormality associated with RPL. The fetal survival rate in women with untreated septate uterus is 6 to 28%, and the miscarriage rate is more than 60%. The longer the septum, the worse is the prognosis. Now coming to the T-shaped uterus. What is the causative factor for this T-shaped uterus? It is nothing but the excess of tissues which leads to constriction rings around the proximal uterine segment, giving rise to a T-shaped uterus. This fibrotic tissue can be a result of infection. In our country, TB has to be kept in mind, or it can be because of trauma. The definite treatment is definitely the hysteroscopic resection. As coming to the leiomyoma, submucous leiomyoma that protrude into the endometrial cavity can impede normal implantation as a result of their position. poor endometrial receptivity of the decidua overlying the myoma, or degeneration with increasing cytokine production. Association between pregnancy loss with intramural and subserous myomas is less clear. The treatment is hysteroscopic myomectomy, but it has to be done only in indicated cases where you feel that it will definitely help this particular couple. Intrauterine adhesions or synecdoche, they lead to pregnancy loss because there is insufficient endometrium to support the fetoplacental growth. It is usually the result of repeated curettage for pregnancy complications, and these repeated curettage, especially within the first 4 weeks postpartum, traumatizes the basilis layer, which then heals via formation of granulation tissue. The treatment of choice is operative hysteroscopy in these cases. Cervical insufficiency is a cause of recurrent mid-trimester but not early pregnancy losses. Cervix is the most neglected part of obstetric sonography. It is estimated that cervical incompetence will complicate anywhere from 0.5 to 2% of all pregnancies and is responsible for approximately 15% of habitual immature deliveries between 16 and 28 weeks of gestation. So just to summarize the anatomical factors responsible for RPL, hysteroscopic surgery is the modality of choice for treating most cases. Post-operative measures to prevent intrauterine adhesion formation should be taken. Anatomical causes are a potentially rewarding etiology to diagnose and treat. Coming to the immunological factors, remember, each step in the establishment of normal pregnancy has been implicated as a possible site of immune-mediated reproductive failure. Both autoimmune and alloimmune mechanisms have been proposed, and since the mechanisms that allow a mother to tolerate her semi-allogenic conceptors are not well defined, it is difficult to assess the role of aberrant immunological factors in reproductive failure. Several autoimmune diseases have been linked to poor obstetric outcome, but antiphospholipid syndrome is the only immune condition in which pregnancy loss is a diagnostic criteria for the disease. Primary antiphospholipid syndrome refers to the association of adverse pregnancy outcome and presence of antiphospholipid antibodies. Which antibodies to test? As there are number of antibodies which have been studied, but the antibodies with the greatest significance and association with obstetric events are lupus anticoagulant and anticardiolipin antibodies. So how to diagnose this primary APS syndrome? This is based on clinical and laboratory criteria. There has to be one obstetric or thrombotic criteria and one laboratory criteria should be present to diagnose this syndrome. Other autoimmune diseases has to be ruled out to make the diagnosis. What are the obstetric criteria? 3 or more consecutive spontaneous abortion before the 10th week of gestation, 1 or more unexplained fetal death at or beyond the 10th week of gestation, severe preeclampsia or placental insufficiency necessitating birth before the 34th week of gestation. The vascular thrombosis criteria are as follows: unexplained venous thrombosis, unexplained arterial thrombosis, small vessel thrombosis in any tissue or organ without significant evidence of inflammation of vessel wall. The laboratory criteria are the presence of anticardiolipin antibody, IgG or IgM isotype in medium to high titers by standardized ELISA assay, lupus anticoagulant present. A positive test has to be repeated on at least one more occasion 6 weeks apart to fulfill the laboratory criteria. There are certain pitfalls in the diagnosis of this syndrome. Usually it is an overdiagnosed syndrome, not meeting the clinical and the strict laboratory criteria by the clinician, not repeating the lab test at 6 weeks, non-standardized ELISA for anticardiolipin antibodies, and there can be interlaboratory variations for phospholipid-dependent coagulation test used for screening for lupus anticoagulant. Remember, you can also get false results in this syndrome. If it is improperly collected and processed sample, there can be temporal and trimester-wise fluctuations. VDRL positive patients who may or may not have syphilis. There can be general infections and inflammations which can also give you false results. Coagulopathies and anticoagulant medication users including aspirin and heparin can also give you false results. Management: if the woman is having PAPS without a history of thrombotic event, then we give prophylactic therapy such as aspirin and heparin in pregnancy and continue till 6 to 8 weeks postpartum. If the woman is having PAPS but along with it she has a history of thrombotic event, then this woman needs full anticoagulation with heparin or warfarin in pregnancy and postpartum. When to start? Aspirin can be started when pregnancy is being attempted or documented, but heparin should be started as soon as cardiac activity is documented on transvaginal scan. What should not be done in PAPS by the clinician? Steroid therapy should be avoided for PAPS because it significantly increases morbidity in the form of hypertension, diabetes, preterm birth without any demonstrable benefit. Immunoglobulin therapy is experimental and it is not for clinical use at present. Coming to endocrine factors, they may account for 15 to 60% of RPL, can be luteal phase defects, thyroid dysfunction, diabetes mellitus, hyperprolactinemia and polycystic ovaries. Can diabetes mellitus be a cause of abortion? Although rare, but poorly controlled diabetes mellitus is associated with early pregnancy loss. The increased risk in poorly controlled diabetic woman is believed to be secondary to hyperglycemia, maternal vascular disease, and possibly immunologic factors. There is no increased risk of miscarriage in those women who have well-controlled diabetes. The miscarriage rate may be as high as 20 to 40%, which is higher than baseline rate in general obstetric population in cases of those women who have polycystic ovarian syndrome. The mechanism for excess pregnancy loss in these patients is unknown but may be related to elevated LH levels, high testosterone and androstenedione concentrations, or it can be because of insulin resistance. Some studies have reported an increased rate of fetal loss in those women who have high serum thyroid antibody concentrations, thyroid peroxidase or thyroglobulin, including those women who are euthyroid. Coming to hyperprolactinemia, normal circulating levels of prolactin may play an important role in maintaining early pregnancies, and prolactin levels during early pregnancy were significantly found to be elevated in those women who gave history of abortion as compared to the normal woman. Progesterone is required for successful implantation and maintenance of pregnancy. Therefore, disorders related to impaired progesterone production or action are likely to affect pregnancy success. A defect in corpus luteum function, that is luteal phase defect, has been hypothesized to be a potential cause of impaired progesterone production, which can result into infertility or pregnancy failure. Genetic factors are a major cause of clinically recognized miscarriages. Parental chromosomal abnormalities occur in either partner in 5 to 7% of couples with recurrent miscarriage, while the rate in the normal population is approximately 0.2%. Balanced translocations in either parent, including reciprocal and Robertsonian translocations, are the most common abnormalities detected in about 4% of couples with recurrent miscarriage. The other chromosomal abnormalities include inversions and sex chromosome abnormalities. Translocation is exchange of chromosomal segments between two non-homologous chromosomes. There are two major types of translocations. It can be Robertsonian translocation or a reciprocal translocation. Inversions are also of two types, can be pericentric or paracentric. To diagnose genetic factors, you have to do the karyotype of the abortus, or you have to do peripheral blood karyotype of the parents in all couples with recurrent miscarriage. Coming to thrombophilia and fibrinolytic factors, Thrombosis of spiral arteries and the intervillous space on the maternal side of the placenta can impair adequate placental perfusion. The resulting abnormalities of the uteroplacental circulation may cause late fetal loss, intrauterine growth restriction, placental abruption, or preeclampsia. A relationship to early pregnancy loss is less clear and may be restricted to specific thrombophilic defects that have not been completely defined or the presence of multiple defects. There is a large and contradictory literature on the association between maternal inherited thrombophilia and or RPL, which occurs in the first trimester. Some infections can cause abortions like listeria, monocytogenes, toxoplasma, cytomegalovirus, and primary genital herpes. They can cause sporadic pregnancy loss, but no infectious agent has been proven to cause recurrent pregnancy loss. Women with unexplained recurrent pregnancy loss, they have a higher incidence of elevated day 3 FSH and estradiol levels as compared to women with a known cause of RPL. So as the day 3 serum FSH level increases, the quality and quantity of oocyte decreases, and that might lead to pregnancy failure in those women who have decreased ovarian reserve. Although a frequent concern of patients, there is no high quality evidence showing a relationship between RPL and occupational factors, stress, or low level exposure to most environmental chemicals. Chemicals that have been associated with sporadic spontaneous pregnancy loss include anesthetic gases, that is nitrous oxide, arsenic, aniline dyes, benzene, ethylene oxide, formaldehyde, pesticide, lead, mercury, and cadmium. The other causes in the form of personal habits, it is not clear, but the association between RPL and obesity, smoking, alcohol use, and caffeine consumption is unclear. These factors may act in a dose-dependent fashion or synergistically to increase the rate of sporadic pregnancy loss. So in the evaluation, now we know the causative factors. The clinician has to give them lot of time, go through their bunch of papers and take a thorough history to find out the probable cause of RPL in this particular woman. Next step is physical examination, systemic examination, pelvic exam, and transvaginal ultrasound. This is the summary slide for the investigations according to the causative factors. In the evaluation, the tests which are not useful and should be avoided are anti-nuclear antibody test, maternal anti-paternal leukocyte antibodies, mixed lymphocyte maternal paternal cell cultures, HLA typing, and immunophenotypic panels. This was all focused on the female partner. But can there be a male factor responsible for a recurrent pregnancy loss? Because the sperm integrity is required for sperm-egg interactions, fertilization, and early embryonic development, and sperm quality is associated with the embryo's quality to reach the blastocyst stage and progress to implantation. Microdeletions of the long arm of the human Y chromosome are associated with variable spermatogenic failure. Y chromosome microdeletions are found in approximately 7% of men with very low sperm counts. These men, they also often show a higher incidence of sperm chromosomal abnormalities. An elevated rate of sperm chromosome abnormalities has also been found in some men of recurrent miscarriage couples. A recent study reports that the incidence of sperm chromosome abnormalities is 16.5% in male partners of women suffering from recurrent miscarriage, while the incidence is around 5% in controls. So, DNA fragmentation test is advisable in those couples who suffer from recurrent miscarriages. So, coming to summary and recommendations, RPL refers to the occurrence of 3 or more consecutive losses of clinically recognized pregnancies prior to the 20th week of gestation. Ectopic, molar, and biochemical pregnancies are not included. It may be primary or secondary. 0.4 to 1% of women have 3 consecutive pregnancy losses. 3 to 5% of couples with RPL have a major chromosomal rearrangements versus 0.7% of the general population, usually a balanced translocation. Recurrent aneuploidy also appears to play a role in RPL. Chromosomal abnormalities are the most common cause of sporadic early pregnancy loss, accounting for at least 50% of such losses. Uterine abnormalities, both acquired and congenital, have been reported to be responsible for 10 to 50% of RPL. Pregnancy loss is one of the diagnostic criteria for antiphospholipid syndrome. Endocrine factors may account for some cases of RPL. There is no high quality evidence showing a relationship between RPL and occupational factors, stress, or low level exposure to most environmental chemicals. RPL typically occurs at a similar gestational age in consecutive pregnancies. The recurrence risk increases as gestational age at the time of loss increases. All said and done, whatever we talked till now was applicable to only 50% of the cases of RPL. As 50% of these cases, they remain unexplained despite doing a battery of tests on them. But prognosis is still good for them, as more than 50% live births are reported in these cases of unexplained RTL even without any intervention. The role of tender loving care for both explained and unexplained RPL cannot be underemphasized. It has to be offered to each and every couple who comes to us with RPL. Friends, this is the ICOG Ignite, which we published last year. This has been uploaded on the ICOG website. We have covered A to Z of recurrent pregnancy loss in this publication. You all can go on ICOG website and download this Ignite for your further reference. Thank you so much, dear friends, for your patient hearing.
That was an excellent presentation, Lakshmi, and wonderful overview of everything. And importantly was also a stress on the fact that the male factor in recurrent pregnancy loss is something that we require to stress into. And sometimes we are looking at a usual universal approach, looking at it as a immunological thing, but which you clarified that there are so many other factors also which we require to look into. Thank you so much. I think, Pratik, are we taking questions at the end of the session or now?
We can take the questions now, ma'am. There are some relevant questions. There are a lot which may be irrelevant or already have been covered in Madam's talk. So we'll try and avoid those. Some of the relevant ones I'll be reading out. The first one is from Dr. Vijay Lakshmi. Her question is gravida to abortion 9 weeks. Patient has on and off bleeding PV. Would you consider this patient to be a high risk for recurrent pregnancy loss, or would you investigate her as a standard threatened miscarriage?
Her first, she is gravida 2. So what was the outcome of first pregnancy?
Gravida 2, abortion 1. It was a first trimester loss.
Yeah. So according to the definition, she is not high risk because I said ki it has to be have the at least minimum 2 losses. Correct. So she is not high risk, but anyway, if she is complaining of bleeding PV in this pregnancy, so anyway, you have to monitor her more stringently as compared to other pregnant women who are not having complaint of bleeding PV in the first trimester. So just per se, because she is having bleeding PV, she is more at risk of aborting in this pregnancy. So the clinician has to manage as a case of threatened abortion and not as a case of RPL.
So all that entire battery of tests which you showed us, which is quite scary sometimes for patients.
No, we should not do.
That entire battery is not to be recommended during pregnancy at least.
Even in cases of RPL, Pratik, the take-home message from my side is that the clinician should not panic first themselves. They should not panic. They should not panic the couple. They should not prescribe all the tests which are available in our armamentarium. That is what I said. They have to give and devote time. Take a detailed history. Find out the probable cause in your mind. And then accordingly you advise the test, considering that the result of those tests will definitely help you in finding out a further plan of action for these couple. Otherwise, please don't advise unnecessary tests for these couples.
The next question is from Dr. Priyanka, and she is asking whether you recommend serum progesterone levels in early pregnancy for PCOD patients.
No, in my
Is there any
practice,
clinical relevance?
No, I don't do the serum progesterone levels.
I think pretty much in infertility also we rarely do serum progesterone levels these
never
days.
do.
And in pregnancy, of course, the levels would vary quite significantly, and there is no nomogram or standardized value, so it's not really very practically significant.
And anyway, we will be giving empirical progesterone to our patients if she comes to us with a history of one abortion. So, I mean, we don't do evidence-based practice in RPL, and why we don't practice, I have already told you in my one slide. So
Yes.
we all try our level best, and most of the times we do prescribe empirical medicine, and progesterone is one of them. We do give them natural micronized progesterone or dydrogesterone in our practice in the first trimester.
Thank you.
And in this particular patient, may I just interrupt, Lakshmi? I think
Yes, Girija, yes.
Do a proper per speculum examination because
yes,
a local organic pathology like a polyp or something which is
yes, cervical erosion, polyps,
That sonography test, and then suddenly we turn out to be landing with a surprise later.
Because per speculum examination is becoming a foregone art in the gynecologist armamentarium. They just put a TVS probe and they don't remember to do a PS examination.
Ma'am, anything regarding preconception HSG?
Preconception?
HSG?
If you are suspecting anatomical factors, if you yourself are doing a transvaginal sonography, then you can really pick out if you are suspecting the anatomical factors. If you are not suspecting anatomical factors, then I don't think so you are justified in ordering a HSG for this woman. And if you are suspecting anatomical factors, then hysteroscopy, laparoscopy is the gold standard rather than going to a HSG first and then ordering a hysteroscopy for her. Because hysteroscopy will provide you a see and treat approach.
So there's one last question. This is from Dr. Manju Sharma. It's a slightly long question. Please bear with me while I'm reading it out. My patient, aged 31 years old, had a scanty period on her due date. She continued to have blood-stained discharge. After 5 days, UPT was positive. She was put on progesterone twice a day. Stopped after 7 weeks when her fetal heart was seen on ultrasound. The fetal heart was seen on ultrasound at 10 weeks, but later on she had a missed abortion of 8 weeks. That was evacuated. So in the interval between this pregnancy and the next pregnancy, what tests would you recommend for this particular patient?
If she has a missed abortion, then before she attempts pregnancy, I will definitely recommend the karyotype of the husband and wife. And if she is doing, nowadays, majority of missed abortions are tackled by medical means. But if she is doing a evacuation and she is getting POCs, then she should send it for the karyotype evaluation. That will help her in managing her further pregnancy. Girija, you can add.
Yeah, I would also like to give an attention to looking at other parameters like hypothyroidism. Yes. I rest very heavily upon weight loss in my patients and looking at micronutrient deficiencies, because sometimes there can be an underlying hyperhomocystinemia and hypothyroidism. So all these holistic things and trying to optimize their health, including immunization before conception next time, would be the right approach that I would consider in these patients. I think I would want to make a point here, since Lakshmi is there from the ICOG, Pratik is there, Sarita is there, and Sampath Kumari madam, such very senior stalwarts are here. We have always been speaking about sonography training from the foray of FOXY, and most of the attention is given to obstetric ultrasound training. I think we must start now promoting and talking about doing gynec ultrasounds, which can reach out to places like we are now in Guwahati, where many times the radiologists are not really sensitized to what we as gynecologists need. And therefore, there has to be a separate kind of a short diploma, something which will enhance our gynecological ultrasound techniques and skills. And I think, Lakshmi Madam, you can take this as a proposal or an idea. It suddenly struck me, why don't we do this? Because when we have to have so many RPLs and things like that, we can do our own gynec ultrasounds. As an
Thank you, Girija. It is really a nice suggestion, but it is already in my mind and I am working on it because, as you rightly said, there has to be a training course for gynec ultrasound, which is much needed by our members.
Because when you mentioned that you have to do your own ultrasound,
Yes.
I was just thinking, what will people in Guwahati do? Because it's very easy for me to just tell my sister who is a radiologist on our radiology department. But this may not be possible for everybody, you know. So
Yes,
it's always
yes.
better to be armed with your own techniques and skills. Thank
Because
you so much.
Definitely.
gynecologists should do their TVS themselves, because then only you can interpret it in a better way, because you know the clinical aspect, you know the clinical side, and then you are doing the investigation, because radiologists, what they will write, they will see and please correlate clinically. So
Yeah.
now the ball is again in your court. You have to correlate it clinically. So it is better that you do your TVS and you can correlate in a better way.
Thank you
Yes,
so
good
much. I think
suggestion.
we move on to the next session, Pratik, with your
Yeah,
permission.
yeah. Any closing remarks from Dr. Navanita Deka before we move to the panel
Yes,
discussion?
thank you, Lakshmi Sikande ma'am. It is an excellent talk and good interactions also. Thank you.
Thank you so much to both our chairpersons and respected Dr. Lakshmi ma'am for a fabulous lecture. And we continue with the theme of recurrent pregnancy loss with a panel discussion on the same. Shrimon, can we have the presentation of CVs please so that I can formally introduce them? In the meantime, I'd like to announce that we have an attendance of nearly 500 viewers online, which is a weekday afternoon gathering, which is excellent, I think, considering in these COVID times when it's raining webinars everywhere. That's a fabulous attendance to have. So thank you, TOG team, Science Integra, and of course to Shrimon, Subbu, and Session, the team behind this entire series of programs. We move on to the panel discussion. It's my proud privilege to introduce our moderator for today, Dr. Sarita Bhalerao, Vice President of the Mumbai OBGYN Society, to which I also belong. She's been a past chairperson of the Foxy Quiz Committee from 2009 to 2011. She's a member of the ICOG Governing Council, recently elected, past secretary of the IMS Mumbai chapter, immediate past president of AMWI Mumbai branch, and joint secretary of Foxy 2017 when Dr. Rishma Dillanpai was the president of Foxy. Next slide, please. Again, it's a privilege to introduce the vice president elect of Foxy for next year, Professor Dr. Sampath Kumari. She's a deputy director and professor of obstetrics and gynecology, retired from Chennai. She's been a past chairperson for the Foxy Adolescent Health Committee from 2016 to 18, governing council member of ICOG, joint secretary for IMA Chennai South branch, president of Board of Studies of OBGYN at the Tamil Nadu MGR Medical University, treasurer and past secretary of OGSI, the OBGYN Societies of South India, a multitude of presentations and publications, a host of awards to her credit. She's the expert on today's panel. Welcome, Dr. Sampath Kumari. Next slide, please. We have amongst us a very young, dynamic OBGYN from Noida. She is a past member of the Foxy Endocrinology Committee when I was chairperson. Dr. Manisha Saxena, she is a DGO from KGMC Lucknow and also has an MRCOG from the UK. Fellowship in Minimal Access Surgery, a postgraduate diploma in sonography, and currently she is a consultant in OBGYN at the Kailash Super Specialty Hospital in Noida. She's also been a joint treasurer for the North Zone Yuva Foxy when it was held at Noida last year, and she is also an active member of many societies. Welcome, Dr. Manisha Saxena. Next slide, please. Dr. DP Agarwal has sent us a very short CV, but she is amongst one of the most active people that I have seen from the Guwahati Society. She is a consultant OBGYN and infertility specialist at Dispur Hospitals. And we welcome you, ma'am. We await to hear your contributions in this panel discussion on recurrent pregnancy loss. Next slide, please. Professor Dr. Panchanand Das is an institution in himself, one of the senior most OBGYNs of the entire Northeast. He is the professor and HOD of the Department of Obstetrics and Gynecology at Tezpur Medical College in Tezpur in Assam. Welcome, sir, and we are privileged to have you amongst us. Next slide, please. Dr. Ritu Santwani is well known to many of us, but to formally introduce her, she is obstetrician, gynecologist, and cosmetic gynecologist. Can we have the audio off, please? Okay, there's some disturbance in the background, but I'll continue.
Not required. Just open the PPT right now.
She's an IVF specialist and has a clinic of her own in Pune, and she is also an honorary professor of obstetrics and gynec at the VIMS Medical College. Welcome, Dr. Ritu Santwani. I think that's the last of them. Have I missed out anyone? Oh, yes. There's Dr. Nilakshi Fukan Kumar. I'm sorry. She's a consultant at Downtown Hospital, and she's also a visiting consultant at Pratiksha Hospital in Guwahati. She's a former secretary of the Guwahati Obstetrics and Gynec Society, former secretary of IMS Guwahati chapter, joint secretary of AICOG at Guwahati, and president of the Guwahati Menopause Society. So I think we have a good mix of senior and eminent consultants from local society as well as national faculty. And to further proceed with the panel discussion, I'd like to hand over to Dr. Sarita Palera. Thank you so much.
Thank you, Pratik. Thank you for that kind introduction and for giving me this opportunity. It's wonderful to see everybody from so far connected together. I think it's really quite amazing. So can I share the screen? Can I be allowed to share the screen, please? I'm going to open my presentation and we're going to discuss some of the important issues related to this. Yeah. Okay. Okay, can you see my screen? Is it fine?
Yes, Sarita.
You can. Okay, excellent. So let's start at the, 1 second, I'm just trying to change the slide and I'm going to go ahead and let's start at the very, very beginning, and I'm going to ask Professor Das the first opening question, and that is, what is the definition? How do we define this difficult condition, and have we come to a consensus after all these years?
RPL is classically defined as singleton pregnancy loss in 3 successive pregnancies. It should be clinically defined pregnancies. Many people is to cover it up to 24 weeks, but in some situations they are covered up to 20 weeks. RCG agreed covers 3 consecutive pregnancies, but American Society, it covers only 2 consecutive pregnancies.
Thank you, sir. I'm going to ask Dr. Sampath Kumari, madam, now. Yes. When would you really, what do you think is more realistic, 3 or 2? And when would you start investigating the patients?
These patients, good afternoon, Sarita. Whether the RCOG or AS or American Society guidelines is there, nowadays the couple, they wish to have only one baby now. So if there is any single loss of even in the first trimester itself, I don't want to, as Lakshmi madam told, don't want to do all investigation, but it has to be considered. After the single loss itself, though the guidelines and definition tells the 2 or 3 loss, we should not allow for the second loss. At least the minimal investigations to be done. If a patient of about 38 to 40 years becoming pregnant and she is having the first pregnancy loss, means we cannot allow her to go for a second loss. So some basic investigations, which are not a lot of investigation from starting from thyroid to karyotype, but some basic investigations I would like to do.
Absolutely. So I think what you're trying to say is that initiate the evaluation appropriately after 2 losses based on the patient's age and desire. So let's go ahead now, and I'm going to ask Dr. Ritu Santwani. Dr. Ritu, can you tell me what is the incidence of RPL in your practice, in literature?
Yeah. A very good afternoon to you, Sarita ma'am.
Good afternoon.
Yeah, and thank you, Dr. Tambe, for giving me the opportunity. Ma'am, with your permission, can I add 2-3 lines extra regarding
Of
the
course.
classic? Yeah, thank you so much, ma'am. As the Dastar has correctly mentioned regarding the 3 or more consecutive pregnancy loss, yesterday when I'm going through this Green Talk guidelines, as Lakshmi ma'am has also mentioned regarding this primary RPL, in which who has never had the previous any viable infant, and in the secondary RPL in which there is a history of previous normal infant or the pregnancy beyond the 20 weeks, and there is one more recent is added in that is the tertiary RPL, in which the female who has a history of multiple miscarriages interspersed with the normal pregnancies. Now coming to this incidence, ma'am, in my practice, I am having a lot of, means I can say around 5 to 6% I am getting the patients of this. Yeah.
Okay.
Yeah. Thank you so much, ma'am.
Okay. So let's go ahead now, and I'm going to ask Dr. Nilakshi the next question. My question to Dr. Nilakshi is that if you have to broadly outline the causes, how would you classify them?
So for the causes of recurrent pregnancy loss, it is very confusing because maximum, almost 50% is unexplained. And after that, you can consider the chromosomal abnormalities, some genetic problems, uterine anomalies, anatomical anomalies, autoimmune causes, thrombophilia, endocrine causes, and infection is a big query you can put. That is
Right. So you say that almost after doing all the tests, almost 50% of them will still be unexplained, which is very difficult to explain to the patient.
Sarita,
so let's go
shall I
ahead
tell
now.
something?
Yes, sure.
See, this during this COVID situation, most of the patients who were on infertility, I don't know about your place, in Tamil Nadu, in near Chennai places, most of the infertility patients who didn't have a baby, now they have become positive. I think this COVID has made the stress free and the time to then, and the environment is so clean. We don't have any. I don't know about your place.
So much pollution.
It's same here. We also experienced the same experience.
Okay, come and tell I am positive. I am positive now.
Yeah. That's a pregnancy positive.
That's good. Let's go ahead now, and I'm going to ask Dr. Manisha Saxena the next question, and we're going to come to cytogenetic abnormalities. And the questions are, what are the common abnormalities that cause recurrent pregnancy loss?
Good afternoon, madam and everybody. So it is my privilege to be with you all on this platform, and I thank Dr. Prateek Tambe sir for this opportunity. So, madam, as you asked that as we are enlightened by the talk by Madam Dr. Lakshmi Shetty, as she told now, that the chromosomal abnormalities they make up to 60% of cases of recurrent pregnancy losses, and they can be classified means according to the karyotyping when we done on the miscarriage conception. It can be the whole gene disorders, the partial gene disorders. There can be translocations, balanced translocations or reciprocal translocation, and some deletions and other microRNA defects. They can also cause it.
Any common ones that you have seen in your practice now that we are doing more and more karyotyping of products of conception?
And the balanced translocations, they form the major part.
Okay. So let's go ahead and let's basically see. And I'm going to come back to Dr. Das. Coming to you, what typically would make you suspect as chromosome abnormality?
In most of the anembryonic pregnancies, we suspect some sort of.
Okay, so the earlier the pregnancy occurs, the more chance that it is a chromosomal abnormality. Dr. Sampath Kumari, in your experience, what chromosomal abnormalities have you come across?
No, here only this aneuploidy cases like that. I'm working with a government setup. We don't see with most of. We refer to the genetic department. Most of the time it is with aneuploidy only rates of.
You see aneuploidies.
Yes.
Yeah, but I'm finding things like Turner syndrome, the trisomies, these are all we are picking up more and more now that we're doing products of conception. So, Dr. Ritu, in your practice, do you do products of conception karyotyping after 2 miscarriages, say?
Yes, ma'am. Yes, ma'am. I'm doing.
You are doing products.
Yes.
How are you sending it? Can you give us some pointers?
Yes, ma'am. Ma'am, I usually, if the fetus is less than 15 weeks, in that condition, if possible, we are sending the full fetus, and along with that, we are sending the maternal blood also to rule out for the maternal blood contamination. Minimum 2 ml of the maternal blood we are sending in the EDTA vial.
Okay, and how are you sending the products of conception?
Ma'am,
suppose you're doing a DNC.
Yeah. Ma'am, we are collecting in the normal saline. Yeah, ma'am. The kit is provided by the genetic labs. In that, we are collecting.
Okay. Okay. So, are you using a manual vacuum MVA syringe? Because otherwise, how do you collect it and how do you ensure sterility?
Yes, ma'am. I'm using the manual vacuum syringe.
Manual vacuum.
Yes.
The MVA syringe, and you're collecting in that. And suppose
are you using 1 minute, Sarita? Are you using the water or normal saline to collect that products?
Normal saline, ma'am. We are to
collect it.
Yes.
Sometimes they give a medium. Sometimes you can collect it just in normal saline or in distilled water and put a little antibiotic.
Yes,
now the question is that suppose you do this and you do come across some abnormality, then Dr. Nilakshi, what would you do further? What is the next step?
The next step, we like to go for the parental karyotyping.
Okay.
Parental blood karyotyping of the parents.
Yeah, and suppose you do find some sort of abnormality in the parents, then what would you do?
Yeah, like there may be balanced translocation in the this one of the partners. There we have different options. Even with the abnormalities, some patients they go for a spontaneous live birth, though the incidence is less. Either we can go for ART procedures, go for either the sperm donation or ovum donation, and we can go for PGD, take out the normal embryo and put it, go for a ET. All these are the options are available for us once we go for the parental karyotyping.
Right, but I'd like to ask my panelists, would you take a genetic opinion? Is it available where you work? Genetic counselors, are they available? I can see Manisha is saying yes. So in Noida, is it available? Would you like to tell us?
In Chennai also, madam.
Okay, so you would take a genetic opinion and they would go for genetic counseling. Is that the right thing? Yes. Okay, so now we know that in advanced maternal age is one of the important things and one of the important reason, and these are the common things I think we've all discussed: trisomy 16, 13, 18, and I'm going to look at the last line and ask, what is the role of microarray rather than a traditional karyotype? Dr. Dippy, would you like to take that up?
Okay, ma'am. Actually, in a microarray takes up all the chromosomes and it can study the various anomalies and detect it. But in the traditional karyotype, because it is mixed with the maternal tissue most of the time, some it might be destroyed and some might be missed.
Right.
Nowadays, usually microarray is what we do.
You're doing microarray. Okay, so though it is a little more expensive, you prefer to do a microarray. So today we have many things available. You can do traditional karyotype, you can do fish, you can do microarray. Even genetics has really come up in a very big way. So I think best to discuss with your geneticist and decide what to do. And this POCs is very important. Collect in a sterile container with gentamicin, and ready collection tubes are also available, and one can do a fish also if necessary. So I think we've gone through most of these things. A few words about single gene disorders, and I'm going to ask Dr. Das, would you like to comment what are single gene disorders?
Single disorders are mostly we get sickle cell anemias, alpha thalassemias, and some muscle dystrophies.
Okay, so these are usually not linked to early miscarriages, but perhaps later, fetal losses and later pregnancy losses. just to keep this in mind. Okay, so I think Dr. Nilakshi has given us this very nicely, that you do peripheral blood karyotyping for the couples, you take a genetic counseling, you take an opinion. Options are use of donor gametes, and today we have the option of PGD. So Dr. Ritu, what is the role of PGD? I'm going to ask you.
Ma'am, if these kinds of patients are coming, definitely we do the proper counseling, and mostly if the patient is ready, definitely we prefer to go for the PGD in these cases.
Okay. Okay, so that is one of the options, and that is coming up. So let's change gear now and move to another area of recurrent pregnancy loss, and that is with the thrombophilias. And Dr. Nilakshi, would you like to set the ball rolling, and how do we investigate for thrombophilias?
Thrombophilias mostly like we go for, it may be inherited or it may be acquired thrombophilias. So in that cases, we may go for APL.
Let's talk about inherited thrombophilia, since you mentioned that first. Would you like to tell us what are the inherited thrombophilias? Some common ones, Dr. Nilakshi?
Like this factor V Leiden mutation, prothrombin gene mutation, deficiency of natural anticoagulant protein C, protein S, antithrombin 3, and this is mostly associated with early pregnancy loss. So these are the tests mostly we will like to go for.
Okay. Now, Dr. Sampath Kumari, would you like to tell us what typically is the history of will make you suspect a thrombophilia?
Thrombophilia, that usually the family history, anything if present, only inherited this protein C, normally the coagulopathy, I think I have not come across these cases. So ask better, someone can explain, I think.
Okay. So anybody, Dr. Manisha, would you like to take that question? Dr. Manisha, is she there or is she on mute? Yeah. Yes, you're audible now. Yes.
So, the inherited thrombophilias can be diagnosed by the history, taking a detailed history of the patient. If she has any history of thrombosis in her or in her close family members, or there is a history of the obvious history is the recurrent pregnancy loss. It is a suspicion. If we see that the patient is having 2 or 3 pregnancy losses, and she also has the history of some thrombosis in her family, then we can start investigating on those lines. So for inherited, we can usually we order these tests, like Madam said, protein C, protein S deficiency, and factor V Leiden. And for Apla syndrome also, we write in initial investigation when the patient comes with this history.
Okay, I think typically these patients will have the cardiac activity will first be seen and then it will disappear. Or they'll have IUGR, or they'll have preeclampsia, or they may have maternal history of thrombosis. Then one would suspect some of these things.
Dr. Sarita, only one thing.
Yes.
See, with this history, in these cases, suppose one missed abortion and PAH, if anything history is present, would you like to do this test of protein C deficiency and everything? In which cases we are supposed to do that? To prove that it is a case of inherited thrombophilias. Because in our government setup, we don't do this test.
Yes, of course.
Costly, no? So I won't have
costly.
Well, the moderator can ask question, not the panelist. Still, I'm asking.
No. This is a. I'm very happy to have interaction and very happy to have your questions and comments. But since you've asked the question, let me reply. What I'd like, in Mumbai city, we do have an autoimmune panel, and in patients who've had repeated miscarriages, especially if the cardiac activity was seen and then it went, plus they've had maybe history of an IUGR or a PIH, or an unexplained stillbirth typically, then we do this protein C, protein S investigations and panel. And though it is costly, it is costly, but we do come to know sometimes if they have these things. So let's change gear again and let's now go into acquired causes, and let's go into the Apla syndrome. And I'd like to ask, let's start with Dr. Dipi, and would you like to tell us how you investigate for this Apla syndrome?
Actually, in case we are suspecting APLA, we have to, suspecting from the clinical features, like she has a previous two pregnancy losses or a preterm birth or a hypertension, IUD, from the clinical history or history of thrombosis for that matter, whether it be arterial or venous. And in addition to that, we need the lab findings. So in the lab findings, we'll need on two separate occasions, minimum of 6 weeks apart. We'll have to have either a lupus anticoagulant or anticardiolipin antibodies, IgM or IgG, in medium to high titer. That is above 40. Usually we assume that to be medium to high titer. So that has to be positive for us to diagnose.
Okay.
On occasions, yeah.
Some lab, they give the report as weekly positive. What does it mean? They should give us positive or negative. Sometimes if it is weekly positive means it should be considered as positive, I think. And it has to be repeated after 6 weeks again.
I think so, and I think that if it is weekly positive, you consider it as positive and you give the treatment accordingly. What about some other antiphospholipid antibodies?
Sarita ma'am, Sarita ma'am, here when we are advising the patient for this autoimmune testing, usually the lab is giving all the three parameters. Lupus anticoagulant also they are giving, and anticardiolipin they are giving. Along with this, they are giving anti-beta 2 glycoprotein also. All the three are coming.
If you do a panel of antiphospholipid antibodies, sometimes you are getting, that is absolutely. So there are some others like antiphosphatidylserine, as you said, anti-beta,
yes, ma'am.
Anti-nuclear.
Yes, ma'am. Yeah. Now, coming to anti-nuclear antibodies, that's a very controversial area. Dr. Sampath Kumari, would you like to take that? Because should we be testing or should we not be testing?
It is not a routine. It's not routinely to be tested for this anti-nuclear and other anti-thyroglobulin. Routine, we do only the lupus anticoagulant and anticardiolipin antibodies. Other antibodies, we practically we don't do routinely.
Correct. Because it is said that they may be more common, but their presence or absence has not been shown to predict a subsequent pregnancy outcome. And these are more related to those who have SLE and those sort of other things. Now, let's come to what about the role of anti-thyroid antibodies? Suppose those are present and the patient is euthyroid. Does it make any difference?
Ma'am, if the level is around 4, like TSH is above 4 or above.
Right.
Yeah, then we would consider giving thyroxine.
Yes. Clinical hypothyroidism, in that cases, definitely we have to do this antibodies test. And as she told, positive and more than 4, definitely we can.
Yes. And in case that they are euthyroid, I think they should be followed up because at some point they may develop hypothyroidism very carefully. So I think we've discussed this about how to go into these antibodies. Let's now come to the treatment. And we'll ask Dr. Das, you are from in the big medical college. What kind of treatment are you recommending for APLA syndrome?
It is a very difficult job, to say in one sentence what treatment we give. Basically, we give for all thrombophilias aspirin. Low dose aspirins are given.
Low dose as well. How low?
We can start with 50 to 70.
Okay. Today, many studies are recommending 150
also. 150 now. So the low dose is 150 milligram nowadays.
We are still, I believe, we are giving depending on body weight 50 to 75.
Okay.
We are mostly giving in the range of 50 to 80.
Okay. So I think 50 to 80 is universal, and now they have recommended 150, but everybody is not following that.
Yeah.
Anything else? What else?
And in some cases, we are using heparin, low molecular heparin.
Okay. In what dose are you giving?
We are giving 40.
Subcutaneously daily, is it? And when are you starting and when do you end it?
We start it after the cardiac pulsation is available or it is heart.
Okay.
And we here in this school, we are giving it and practicing it, and we stop it around 7 days around 7 days before expected date of delivery or before planned delivery.
So you're giving it right up to 38 or 39 weeks, is it?
Yes.
Yes. Okay, Dr. Manisha, what is are you following the same protocols?
And according to body weight, we also give low molecular weight heparin, around 40 to 60. Sometimes it is 40 if the patient weight is less, or 60. There is a RCOG guideline. There they have given a table, so you can find out in which weight category she comes. So generally it is 40 to 60 international unit, but usually we stop it around 36, 37 weeks.
And how do you monitor these patients who are on low molecular weight heparin and aspirin?
Madam, the guidelines says that it should be monitored by PT, MTT and levels, PT and R levels. But means it is such a low dose that we don't we think that there is no need to monitor by lab parameter.
Okay. That is only one thing. Manisha, if you are going to stop with the 36 to 37 weeks means, or you plan for termination at 38 weeks, or will you wait till 40 weeks?
Madam, the patient can itself go in labor after 37 weeks. That's what we think. So we think that it is safe to stop it at around 36, 37 weeks of gestation.
Yes, I think that's what I'm also following. We stop at 36 weeks, we monitor them carefully, and then based on the situation, either we induce or we do elective section or we let them go to term, depending on what they want. That's, the whole point of discussing a birth plan. But what I'd like to ask... Yes, Dr. Ritu, I was coming to you only. So you tell me what you were saying.
Sarita ma'am, in this I will little differ, because earlier the concept was that when the heartbeat is come, then only we are starting the heparin. But nowadays we are starting as soon as the pregnancy test is positive. And in some patients we are starting as the luteal phase support also. Some studies have come also, aspirin to we are giving, but in some patients we are starting the heparin also. And for the doses, I'm agreed with Dr. Manisha, 40 to 60 mg we are giving subcutaneously.
You're giving subcutaneously.
Yes, ma'am.
So you are adding low molecular weight heparin once urine test is positive. But urine test positive does not mean it is a confirmed pregnancy. It may be ectopic pregnancy.
No, sir. Sir, you are correct. I am not denying for that. But sir, these days the guidelines in some patients we are starting in the luteal phase support also once we are doing the IVF. I want to know your opinion, ma'am. Sarita, ma'am.
No, so I'm, I have never started it in the luteal phase, nor do I, as Dr. Das, start it as soon as the UPT is positive. But once I know that it's an intrauterine pregnancy, and maybe I won't wait till cardiac activity, I would start it.
Okay. That's why yes, madam. And that is the reason why I always say the first sonography is always to be done at 6 weeks.
Dr. For in IVF, we would start at
so that you can detect heartbeat.
Pregnancy, we usually
heartbeat is detected. You are very sure your pregnancy is going in proper direction, and if your heartbeat is not there, pregnancy is not going properly.
Ma'am, Dr. Pratik Tambe sir has commented that he is also starting on the day of ovulation.
Okay. Yes, so I think that there are some differing opinions.
Any one of the panelists, are you giving prednisolone?
That was my next question. That is, what is the role of steroids in recurrent pregnancy loss? Dr. Nipi, yes, would you like to take that?
We are not using steroids, but in case of SLE or rheumatoid arthritis, if there are flares or the patient is well controlled before conception, only then we would use prednisolone.
So for this antiphospholipid, previously we were giving, but now we are not giving the prednisolone. Previously, we were giving. Now for the past more than 3 years, we are not giving the prednisolone. As she told, with the lupus, it is given.
Yes, so I think it is only when the mother requires steroids for some reason, but other than that, for the pregnancy per se, we are not giving it. So let's change gears again. Yes, Girija.
About the LMWH, there are small studies which are saying that it is having some beneficial effect on decidualization and trophoblast formation and prevents apoptosis, and that probably is the reason why we find it being given earlier, like Pratik and some of the panelists.
Right.
And the second thing about steroids is we have to be also careful that this can be a sort of a brewing ground for hypertension as well as diabetes. So we have to be very careful in our patients.
Yes, yes, that is true. So I think steroids now is more or less the role is more, out. So let's go ahead now, and I'm going to come to the change gears again. What is meant by alloimmune factors? So Dr. Manisha, can you take that? What are alloimmune factors? Is Dr. Manisha there? I think I can't see her on the screen. Are you there? Or has a...
I'm here, ma'am.
Oh, you're there. Excellent. Would you like to take that? And next we'll come to Dr. Nilakshi then.
Dr. Nilakshi can answer.
Dr. Nilakshi, would you like to take this question? It's a very tricky one. Actually, fetus, the pattern, I mean, it's acts as a foreign substance. Fetus bear a foreign antigen derived from the father, and sometimes it is rejected and sometimes it is accepted. That is the basic theory of alloimmune factors. There is an immunologically, there are, because of the advances in the field of immunology, there is alteration in behavior of the T lymphocytes and tolerance to the fetus. So natural killer cells that is present in the uterus, they are mostly responsible for this acceptance or rejection of the fetus. That is the basic of the.
That is the basic. Yeah.
Yeah.
So
and here, ma'am.
Yeah, Dr. DP.
Yeah, the natural killer cells actually, the peripheral and the ones present in the uterus are little different in their expression of the CD, like they are reverse. The uterine natural killer cells are bright on CD 56 and low on 16. And peripheral are the reverse. And therefore, and it was seen by studies that these natural killer cells, uterine UNC cells, they increase in the luteal phase. In patients who have RPL, it increases even more. Yeah, and therefore these cells, they express glycoprotein receptors, and therefore they were looking for a therapy which would they could attack these receptors and take advantage of this, and that is why prednisolone was being.
Videos on. Yeah. Okay, so let's go ahead now, and we all know that there is some immunological cause, and there are some alloimmune causes of recurrent pregnancy loss. So what are the possible therapies that you could suggest? Dr. Sampath Kumari, would you like to take this?
Yes, I will suggest not a prednisolone. Nowadays we don't give intravenous immunoglobulin in our hospital. We don't. Progesterone, whether there is no negative effect with giving with the progesterone. So since the luteal phase defect also we are not able to prove it. So I will prefer to give progesterone for patients with RPL.
Okay. So what dose of progesterone and what type of progesterone would you like to give?
Now at present we are giving only the natural progesterones of 200, depending on the 200 BD or whatever it is.
Oral or vaginal?
Preferably vaginal.
Vaginal. Dr. Ritu, what about you? What do you think for your IVF patients? What are you giving?
Yes, ma'am. Ma'am, these days the drug of choice is the micronized progesterone. The dose I decide according to the body weight also. So in some patients I am giving 200 BD, in some patients I am giving 400 BD also.
Okay. And what molecule you're using micronized? Is anybody using dydrogesterone? Is anybody would like... Yes, Dr. DP, Manisha, is anyone using dydrogesterone?
Yes, we are using dydrogesterone.
You are using dydrogesterone. Okay, because there are studies that say that
this progesterone also acts as an immunomodulator.
Absolutely, absolutely. So it helps to shift from the cytokine response to maintain the pregnancy. Yes. So that is a very, very important action of progesterone, which is perhaps why it works. So let's now come to PCOS and pregnancy loss. What is the connection between PCOS and pregnancy loss, Dr. Manisha?
That I'm studies also that PCOS increases the early pregnancy losses. It increases the incidence of recurrent pregnancy.
Yes. So do you think that giving metformin will reduce the pregnancy loss in patients with PCOS?
The patient is already on
I think we can't hear you very well.
well, if the patient is already on metformin at the conception, so we don't stop it in the pregnancy, and it definitely helps. Metformin.
Okay.
Manisha, but how long will you continue the metformin? Is there any studies which tells that metformin, the effect to the baby in the earlier stages, and how long metformin will be continued? If a patient PCOS treated on metformin.
Madam, during the first 3 months, we if the patient is on metformin from before conception, then we continue it till first 3 months, and after that we stop it.
That is before organogenesis or after?
Sorry, madam.
No. In the earlier stages, would you like to go with the metformin, and when will you stop? I am asking. Most of the patients, whether proved or not PCOS, they are taking metformin.
I think, yeah.
Dr. Sarita, madam can.
No, so see, so that's why we put this study up where they looked at the loss rates, and it is clear that for PCOS patients with insulin resistance, if you continue the metformin through the first trimester, it reduces the risk of miscarriage, and it may even help them to continue it because it will reduce the risk of gestational diabetes and perhaps PIH as well. So I think now the jury is out and metformin is very safe during the first trimester, and I think the benefits of continuing it are much more than the benefits of stopping it for PCOS patients and with insulin resistance. I know it is difficult to prove insulin resistance, but that subset will benefit the most. So let's go ahead now and change gears and look at the anatomic factors, which Dr. Lakshmi, of course, described very beautifully. But let's ask Dr. Dippy, would you like to say what are the common anatomic factors and how do you diagnose them?
Ma'am, the most common what we usually see which causes recurrent uterine losses, either cervical incompetence or second, I would say, septate uterus.
Absolutely.
Yeah.
Yes.
These two are the most common ones.
Yeah. And how would you, what in the history would make you suspect an anatomical problem?
Trimester loss. Like after second trimester loss, then we would think that it might be a anatomical cause. Besides that, for cervical incompetence, usually if you take the history of the sequence of events during the abortion, we will realize that it's like the painless expulsion. They'll complain of that, or there might be some draining before the expulsion.
Is consequent 3 loss and the cervical length has to be short. When we used to see the NT scan like that, you can see that cervical length, and we can go for a if at all needed.
Cervical length. Yes. And now let's look at the septate uterus. How best to diagnose?
Madam Sarita, can I add one thing?
Yes, Dr. Das. Yes.
If somebody gets one miscarriage at 20 weeks of pregnancy, suppose the lady is primigravida, and if the fetus is live fetus, then you should always think. Because live fetus and dead fetus, the fetus is dead question is somewhat different. Cause is somewhat different. And when the baby is live baby, cause is somewhat different. And probably if there is any live baby, I will always suspect, yes, there might be some anomaly in the tract.
Yes. Dr. Sampath Kumari, for a septate uterus, how best to diagnose?
Only by hysteroscope, better. Hello.
By what about HSG? What about 3D ultrasound?
Yes, sorry. You can ask a OP procedure, you can go with HSG. If facilities are available, you can go with the hysteroscope. By HSG itself, you can the end position.
3D ultrasound is a very good 3D ultrasound is well enough to diagnose the uterine cavity very well. You can go for septate uterus. You can take out the submucous myomas.
Absolutely.
Another one factors for pregnancy loss.
No, I saw a patient. Sorry.
Neelakshi, only one thing, which why I told no, this in a government setup that TV with the transvaginal, so I told if it will be difficult to identify the cases with the strength. So if it is with HSG or hysteroscope, you can, what she told is 100% correct, but still in the rural setup, these things has to be done.
Right, right. So I saw a patient this morning who's had one previous miscarriage, then had a septate uterus, had hysteroscopic septal resection done, and came to me registered now at 14 weeks. Should I do os tightening, yes or no, prophylactically? She's had one mid-trimester loss, then she had hysteroscopic septal resection.
Cervical length is
well, the cervical length, she's now 14 weeks and the NT scan, the cervical length is fine. Should I follow the cervical length or should we go for a prophylactic os tightening in view of the previous anomaly?
To be psychological effect, you can go with a stitch.
Okay.
Like what was the extent of the septum was, if you know how it was resected. Suppose
Absolutely.
it's a very long septum, if you resect from the down and all the septums are resected, then these are the cases where you should put a cerclage, because that
cerclage.
Yeah. Suppose sometimes what you do, we cut it from the above or we leave the cervical part sometimes, and then the competence may be there. So in your case, probably prophylactic cerclage will be a better option, in my opinion.
Will be better option. Yes, I also thought so, because I feel that, we have dilated the cervix to put in an operative hysteroscope, so we have dilated almost till 8.5, and sometimes with a resectoscope dilate almost to 10.5. So in those, okay, let's go ahead now and look into another area, and that is, which are the infections which can cause recurrent pregnancy loss? Yeah. Dr. Ritu, would you like to take that?
Yes, ma'am. Ma'am, TORCH is obsolete now. So these days we are focusing on this chlamydia, mycoplasma infection, listeria, and this HSV, herpes simplex virus. Some cases have been reported recently.
So should we do TORCH or should we not do TORCH?
No, TORCH we are not doing, ma'am.
Is that unanimous with all the panelists?
Yes.
Does everybody say not needed at all? And what do you do when the patient has already had a TORCH and comes to you with this is positive and that is negative? How do you counsel?
मैम व्हाट द पेशेंट आई एम गेटिंग ऑल आर द गूगल से भी, वो पहले से ही मैम सब पढ़ कर आते हैं. मैम हमारा तो आईजीजी है, पहले वाले डॉक्टर ने टेस्ट करा दिया, लेकिन हमने सब गूगल करके पढ़ लिया, दिस इज आईजीजी, उससे कुछ नहीं होगा. मींस द पेशेंट्स दीस डेज.
Yes. So I think that is an important message, and let's go ahead now, that no infectious agent has been now shown to be a cause of recurrent pregnancy loss. It may cause one loss, but not recurrent pregnancy loss. So these spontaneous losses are known with toxo and some of these things. But I feel that rubella we must do, because it's an opportunity to immunize them against rubella. So at least rubella IgG should be positive. Now let's go into what is meant by a luteal phase defect. Dr. Dippy, would you like to take that? What is a luteal phase defect? How do you diagnose and treat? Again, a very controversial area.
Yeah, I don't like to answer that.
You don't want to answer that. Okay. Then we shall ask our senior Dr. Das. Sir, what do you feel about luteal phase defect?
Yes, definitely. There is. I won't say that there is no luteal phase defect. If you agree that luteinization of unruptured follicle, we all agree, and we have seen some cases of luteinization of unruptured follicle. If you agree that, definitely you will have to agree.
Yes. So I think that there is something known as a luteal phase defect, and we do need to supplement progesterone, but it's very, very difficult, and neither serum progesterone levels nor any sort of thing. Yes, Dr. Sampath Kumari, any comment on this?
Same thing. Endometrium or serum progesterone, it is not at all done. So better, if you feel that it is a luteal phase defect, now better to go with the progesterone, as far as I am concerned.
Absolutely. And coming back to you, madam, next question to you is, what about the endocrine factors? What should we test for?
Normally, now I used to tell the universal screening of TSH.
Okay.
Definitely it is done. Then the rule of diabetes, we do the GCT at the first visit itself if the patient is not having vomiting, hyperemesis. So we have to do
GCT?
GCT we do that invariable after diet, 75 gram of that is glucose, and the value will be taken after the 2 hours, and the cutoff value will be the 140.
Okay. Okay.
So the thyroid and diabetes has to be ruled out in the first visit. As with the we are doing the TSH also in the first visit itself. So this two has to be ruled out in all cases, not only in RPL, but in RPL definitely it has to be ruled out.
Okay.
Sarita, can I add?
Yes, yes, of course.
Ma'am, we are in addition, I totally agreed with Sampath Kumari ma'am. In addition, I add the prolactin also and
yes.
and serum AMH also. These days, even the young ladies are coming with RPL history, and sometimes the AMH is very, very bad. So poor.
But what will we do?
We give the DHE and supplements for doing this.
Okay. Is there convincing evidence that AMH, or what do the guidelines say about AMH?
Ma'am, I yesterday only got this. Ma'am, I will share in the group. In the WhatsApp group. A very nice studies I have got from this Green Top guidelines only. That for the role of the AMH for this RPL. I will share in the group. Yeah.
Okay.
But Ritu, that is good for ovarian reserve like that.
Yes.
But, in this, I do not. We are.
Ma'am, I agreed to you, ma'am. Yesterday only I got this study. That's why I have shared here.
Okay.
Now we have to do it. I forgot.
Yes.
Also we have to do it.
We have to do. So now let's come to the end with a even more controversial area, and that is of the male factor. So let's look at the male factor. And I think Dr. Manisha, would you like to take that? Can male factor cause RPL? Yes or no?
Studies that according to WHO parameters, no abnormalities found in the semen analysis of patient with RPL or without RPL. But anti-sperm apart from cytogenetic abnormalities, there is no differences found between semen parameters.
So no significant difference in semen parameters have been found in those patients among men whose partners have RPL compared to the WHO standards. No difference in anti-sperm antibodies, and though DNA fragmentation may result in early embryo loss, this Human Reproduction suggested this in 2006. I think till now we have no clear guidelines on that we should look at the semen analysis. Do you all agree, Dr. Ritu?
Yes, ma'am. Yes, ma'am.
You agree. So, here is a fertility sterility article of 2016, which looked at the relationship between aneuploidy, DNA integrity, all these traditional semen parameters and recurrent pregnancy loss. And look at the conclusion. The increase in abnormal sperm parameters, DNA fragmentation, nuclear chromatin suggest possible causes of unexplained RPL. So, even if we don't test, do you not think that we should treat the partner or treat the husband with antioxidants? What do you think?
I think there is no harm in giving antioxidant to the male partner. If seeing today's scenario that the marriageable age has increased, the patients are so anxious. As Madam said, they want to have one child or sometimes means not even two. So if what maximum we can do, we can give the husband antioxidants also.
Absolutely. Yes, Dr. Sampath Kumari.
About Y chromosome microdeletion. Pratik has mentioned in that.
Yes. That is another cause. But that again is very difficult. See, in those who have severe oligoasthenoteratospermia, we are testing for these things. But only for RPL, I don't know whether we can test. We don't even know whether we should test the semen analysis. So where will we go testing for Y chromosome microdeletion? That is one step ahead.
Male factor, we can give antioxidants.
I think
so. For
yes, I think that not for testing. I think that there's no point in testing, but at least definitely we can treat them, and maybe lifestyle modification. Dr. Das, any comments?
We should give them injection definitely, and definitely we should have changes of lifestyle.
Yeah, and I think little lifestyle correction in terms of exercise, bringing down weight, correct diet will also help us.
Lifestyle is for both male and female lifestyle. 3 meals, 3 snacks, 30 minutes exercise. That is definitely there.
Yeah. That is
3 meals, 3 breakfast.
Yes.
3 meals and
snacks means not fast food. It's only salad, fruits, vegetable like that.
Like that. I know. If only they would follow. What about anything related to environmental toxins? Anybody would like to comment, Dr. DP?
Environmental, actually, ma'am, no definite proof that this particular environmental agent is going to harm, but definitely, too much alcohol, too much smoking, or too much caffeine, for that matter, we would ask the patients to restrict to maximum of 3 cups of coffee a day, not more than that.
So
Yeah.
CK, I saw two papers which told, which has mentioned that with the environmental, that unknown cases we are keeping, no? In that,
Yeah,
with the environmental, if it is corrected, and as I told you in this COVID situations, it has increased the motility and the ovarian effect, everything. Environmental has at least as our statistics 5 to 5%. It
Yes.
will be there.
Yes.
As Sarita ma'am, as you have shown beautifully in the slide, the caffeine intake more than 300 mg per day. Ma'am, in the metro cities, these days so many girls are coming to me, ma'am, हम चाय कॉफी नहीं पीते, हम तो डाइट कोक लेते हैं. So, but in fact, the diet coke, one diet coke is containing approximately 46 mg of caffeine compared to the normal coke, which is containing 34 mg. So, yeah. So, ma'am, thank you for sharing that slide. That is very nice. Yeah.
That's it. And let's look at some new things. Now we have patients who have really everything you have tried, everything. Now, is there any role of immunotherapy? Who would like to take that? I'll leave this open. Any role of immunotherapy? Lymphocyte immunization. So this article, which tells us about immunotherapy for recurrent miscarriage, and it shows that yes, there is some role, and in Mumbai at least we do have centers who are doing this paternal and third party lymphocyte thing, and really they have had success rates also. Dr. Mohan Raut has got a center here, and doing it for unexplained recurrent spontaneous abortions, and his personal studies have shown good results, though we don't have large scale studies and clear guidelines. This is his lymphocyte immunization therapy role in repeated miscarriages and implantation failure. So any comment on this? I think Dr. Nilakshi, we've not heard you for a while. What do you think about this?
Yeah, this is the basic of this treatment, any treatment, especially for recurrent pregnancy loss, because she is very much frustrated after pregnancy loss. So definitely lifestyle management, then counseling. Even if you don't give any treatment, like I have a personal experience, I will like to share with you. We had one patient. She was a case of pregnancy loss. She had already 5 losses, and most of it was a mid-trimester. 2-3 occasions encirclage was given, all sorts of investigation was done, and one point of time she came to me at around 16 weeks just to get the toxoid, and she said, "Madam, I am not going to do any test," and every Monday she walks 5 kilometers to a sheep temple. She goes there, prays, and this time she delivered a baby at 34 weeks. So you can imagine, even with all the treatment, everything fails. Just the counseling, little care, may give us some experience. This is a story I want to share with everyone.
Absolutely, you're so true, and that is why I put up this slide, that they give a ray of hope. It's very important, and even after 3 miscarriages, I tell my patients the chance that you'll have a successful pregnancy the next time is far higher than the chance of having a repeated miscarriage. Even if the risk of miscarriage is 30% or 40%, you still have got a 60% or a 70% chance of a successful pregnancy.
So before, I want to tell one
yes, madam.
Negative effect only. Still, I want to share this. One is a Gravida 5. First, Gravida 1 and 2, she had a missed abortion, but she didn't. Now treatment was given, I think. For the Gravida 3, she was investigated and others was negative, and she had a stitch. In spite of the stitch, she lost the baby at the 6th month. And with the Gravida 4, everything, progesterone, metformin, whatever possible she had, and she was planned for elective LSCS at the completion of 36 weeks. Her fate, I don't know what to say, but at the 35 weeks, she came with a loss of fetal movement and it became IUD. Now she is very, very afraid to become pregnant. These are our very rare cases, but everything is normal. In spite of this, she had stitch and she had progesterone, and she went up to 34 weeks, and finally she came with IUD. So this happens sometimes. So in this medico-legal issues, we should be very, very careful, I think. That developing care, we can tell, but we cannot escape with telling as TLC.
Okay, so let's have one closing, thank you madam, one closing remark from each of our panelists. Dr. Das, would you like to, one closing key message?
Recurrent pregnancy loss cases should be properly evaluated, and I believe the basic cause, those anatomical causes are to be assessed thoroughly, because we are causing some iatrogenic causes for even RPL.
Right. Dr.
I am just giving you two examples. Number one. Nowadays, for postpartum hemorrhage, most of us, we got the experience of giving balloons. No? We insert some balloons, give some free. Now, when do we remove the balloon? After 24 hours. I believe Nilaki will not forget that incident. One night she rang me up, Dada come. We got the PPH. She was in OT. After cesarean section, there were treatment of blood. It was not controlled with our prostaglandin and others. Then we decided I will put one catheter, Hollis catheter with 70 ml of fluid. Then I said, Nilaki, you see the balloon is coming out through the internal loss. So better you remove it. And this is happening to me in other few cases. That has given me some sense. Can this balloon which we are putting inside the uterus subsequently lead to cervical incompetence? We are not removing it in time. Number one. That is one. Number two, we should ask and teach our juniors never to do rapid sterilization of cervix for doing MTPs, DNAs. Number three, if you are practicing with mifepristone and misoprostol, we always have the habit, yes, or she might need one subsequent DNEs or evacuations. And these DNEs and evacuations, this patient is now 1 week old, 10 days old, like that. No? Because they started with mifepristone, misoprostol, she will start bleeding or complete evacuation of uterus after 3-4 days, like that. And she will come for DNA, say after for 7-10 days, like that. Once you do repeat sonography, by the time uterine cavity is infected to some extent. And when you are doing DNAs in these type of infected cases, you are always at the risk of developing synechias, which are iatrogenic synechias.
That's true.
And can we prevent that? We can prevent with some medication probably. And I got a practice, and that practice was taught to me by one anesthetist. He is an anesthetist. He said me, hey, just put some Dexona. What he did was he diluted one vial of Dexona with 5 ml of distilled water. And he asked me, just instill it inside the cavity of the uterus and keep it like that for a few minutes. Superb idea. And I am always practicing that. I never get, in my practice, I am not getting synechia following MTP DNA in my own practice till then.
That's good. Yes, that's an interesting observation.
It is a very, very peculiar phenomenon. And number 4, I have told you 3 things. Number 4 is MTP is bread and butter for all of our beginners. Are we very sure our people are doing MTPs in a proper way? We should be very sure, because we are not teaching them thoroughly, and the motion in which they are rotating the Karman's cannula. Is it a rotatory motion or 2n promotion. If they are doing in a rotatory motion, there is this chance. But if they are doing in a 2n promotion, yes, there is always chance of causing cyanic.
Oh, cyanic, yeah. Okay. Okay. Thank you, sir. Thank you. That is really very helpful. And we'll ask Dr. Ritu. Ritu, any closing remark?
Ma'am, as all of you discussed everything very nicely, ma'am, according to me also this tender loving care is very, very important.
Very important.
And I always tell the patients when they are coming to me, ki once we make the proper diagnosis, you have to think positive. Once you think positive, definitely you will get the positive results.
That's true. That's wonderful. Dr. DP, anything from you?
I would agree with Dr. Ritu, and I would say that there is light after every tunnel. So let's everybody positive. Yes.
Dr. Nilakshi?
Yeah, this was a very interesting and interactive session. I liked it. Only thing I want to say that like while investigating a lady for recurrent pregnancy loss, we should always consider after two pregnancy loss we should consider. And one thing we just missed in the definition, that we should exclude ectopic.
Yes, yes.
Not
of course. That's true.
Yeah, because we have seen that many doctors are prescribing lots of investigations once the patient has because patients are worried. They will ask you that why I have aborted, what is the cause. So we should reassure and reassure her. And
very
true. She will be positive. Thank
Dr.
you.
Manisha?
Completely agree with Dr. Nilakshi madam, as she said that we have to give tender loving care, empathy and support to them and reassurance.
Okay, and Dr. Sampath Kumari, coming to you.
Madam, as I told earlier, depending on the age,
right,
the investigation has to be evaluated. As everyone told, positive effect, tender loving care, and we should give hope to the patient. That's all.
That's true. Well, thank you very much. It's been a wonderful panel, and my thanks to Pratik for organizing this. Thank you, Dr. Lakshmi and Girija, for being there and giving us your valuable comments. And with that, we come to the end. Yes?
Ma'am, most important.
Yeah, Dr. Navanita, sorry.
Yes. Lakshmi madam, do mention, I want to emphasize that proper history taking, the doctor should have patience, proper history taking and seeing the papers. Most important.
You're very true, because otherwise they just write missed abortion. Nobody bothers about whether it was a confirmed pregnancy, whether there was a sac seen, whether heartbeat was seen. So history is really very important. Thank you, Dr. Nabanita, for that point.
Sarita, wonderful panel moderation. Thank you.
Congratulations, Sarita.
Thank you, Dr. Girija, and all the best to you for the upcoming week. Yes, is it next week or the next?
To appeal to everybody to please go and vote on between 1st and 10th September at the foxy.org as Vice President.
Definitely.
Girija, you are in. Don't worry.
Sure, ma'am.
Thank you, madam. Thank you. I need your wishes and blessings.
Thank you. Pratik, thank you very much for the wonderful session. Thank you.
Thank you.
Congratulations everyone for a fantastic panel. I am proud to announce that we have 715 logins.
Wow.
Amazing audience. And there are lots of congratulatory messages and good wishes from the audience. But one comment really stands out. That is from Dr. Shashwati Sanyal Chaudhary, and she said, "Good going, Sarita and Sampath, congratulations." So a fantastic panel discussion, a fantastic moderator, and very learned and eminent panelists. We have maybe 3 or 4 questions which are there. If we have time, then maybe Subhu and Session, can we take those? Is that all right?
Pratik, if you don't mind, can I leave, Pratik?
Yes, ma'am. Of course, ma'am. Thank you so much for coming in.
Thank you. Thank you to all.
So the first of the relevant questions is a patient has a karyotype of 46XX 9QH plus. I think this refers to a chromosomal translocation on the short arm of chromosome 9. Any of the panelists or the speakers can take this. Is this relevant? Does this need to be treated? How do we proceed further? This is from Dr. Pratibha Pasar. I'll just repeat. Patient has a karyotype of 46XX and 9QH. Do you think it's relevant? Do you think we need to do a PGD?
Pratik, I think here we need a genetic counseling
Probably,
done.
yes.
Yeah, and we have to, they have to do a pedigree. They have to look at the family tree. They have to look at the karyotype of both the parents, and then they have to suggest the options. I don't think it's something that we can just, offhand
So
take a
in Bombay,
decision.
in the good old days, we would send to Kotwali Wale or to Dr. Himapuram. I think those were the two authorities
So
that we
that
used
time
to
we were
refer
only
everyone
doing
to.
karyotypes. Now today we are doing micro arrays and confusing, some more arrays are coming up.
Absolutely.
Either
And
we
Pratik,
are clarity or we're getting confusion, we don't know.
Yeah.
Pratik, in this era of evidence-based medicine and so many litigations on doctors, it is always better to send them to a professional genetic counselor so that he
Absolutely.
can guide them in a proper way.
Absolutely. The next question is from Dr. Parul Singhal, and her question is: I have seen some people giving LMWH in BOH till 20 weeks. Is there any such protocol? I think, Dr. Lakshmi, that is a question for you since your talk was on LMWH in RPL.
Yeah, there is network issue. They are continuing till which week you are saying?
Till 20 weeks, empirically, some people are giving LMWH in BOH. Is there any protocol as such? I think you had clearly mentioned in your talk that you can start it as early as possible, but unfortunately, there is no time limit prescribed. There's no upper time limit or there's no cutoff when you should stop,
Yeah,
if
it
I'm not
should be.
mistaken.
It should be started once you document the cardiac activity on your transvaginal ultrasound. I know I went through a lot of literature, but nowhere it is mentioned that you can give empirical, but we do all give empirical, especially in cases of 2 or more losses. But unless she is having a Apla syndrome, we are in true sense not justified in giving her heparin. And yes, many people, they continue it up to 34 weeks. If it is low molecular weight heparin, many people, they continue it up to 36 weeks also. So it all depends on the patient's financial status also. And as a clinician, you are the best judge. So you have to decide first whether it is really indicated in this particular couple. If it is indicated, till how long you want to continue.
Thank you, ma'am. There are two questions from Dr. Neelam Benara, and the first one is: should we do a routine CBC test to know platelet count while the patient is on heparin? I think this was answered in the panel where
Yes.
it was clearly mentioned that if it is low molecular weight heparin, no tests are required because
No
the
monitoring is
incidence of
required. Yeah.
hemorrhage is quite low. If you are giving unfractionated heparin, that is when you need to test, and specifically you need to do a PT-INR and an activated factor 10A. I think those are the recommendations. The second
Yes.
question is: how long can we use metformin in pregnancy, and is there any harm if we continue it in second trimester of pregnancy? Anyone can take that.
Again, it without indication, it should not be started. But metformin is yet not approved by FDA in pregnancy. But again, I will say as a clinician, if you feel you have to start, then have its indication. You should be able to justify the prescription, and yes, you can give.
Thank you, ma'am. I
Means
think
it is
that's
safe
the...
in pregnancy. We do give.
Dr. Tambe,
Yes, sir.
say in PCOS, definitely we are using metformin. There is somewhat different issues, and how long we will continue? We can continue till term, till delivery. If we use also, I believe there should be no harm. Because I have seen many endocrinologists, they use even metformin in GDM cases first. In GDM, they will never start insulin right at the moment. They initially try its medication, diet, and then metformin, and even they give her insulin.
Thank you, sir. Dr. Girija, ma'am, you had a point?
Yeah, I wanted to just say that polycystic ovarian syndrome has given us a huge experience wherein metformin has been found to be beneficial in reducing the possibility of miscarriages. One, and when you extend, plus it has established safety, so we should not have any fear about giving it in the periconceptual period. Secondly, an extended use of metformin also has reduced the incidence of GDM and its consequences. And therefore, we should also extend it towards maybe even using it post-partum. And if you look at the Government of India guideline on GDM, which are very, very clear now and has been published in 2016, reiterated in 2018, mention the use of metformin in patients of GDM. So therefore, whenever you find the PP2 of more than 200, you can just flow in metformin without any worry. So you can continue till delivery, as Professor Das said.
Thank you, madam. Thank you so much. So I'd like to draw this entire session to a close by proposing the formal vote of thanks as convener for today's program. To start with, we need to thank Dr. Alaknanda Das and Dr. Nabanita Deka, the President and Secretary of the Guwahati Society. Thanks also to Professor Gokul Chandra Das. Unfortunately, he couldn't join us today, past Vice President of FOXI. Dr. Girija Wag, taking time out from your busy schedule and chairing the session. Thank you so much for coming, ma'am. To Dr. Lakshmi Shikhande, our chairperson-elect of ICOG, thank you so much for an enlightening talk. I think you covered so much of RPL in that short 30 minutes. Even if somebody blinked, they would have missed a very important point during your talk. Our very excellent moderator, Dr. Sarita Bhalera, who took us through all the different etiologies and evidence-based discussion on how to treat different aspects of RPL, a very difficult task to actually do within 1 hour, but she did it in a very fantastic way. Dr. Samput Kumari madam had to leave, but she gave some very valuable pointers, and I think we are in for a very exciting next year when she is Vice President of FOXI. Dr. D.P. Agarwal, thank you so much for bringing in the ART consultants' view. Since I was not there on the panel, I was afraid that we wouldn't be represented, but both Dr. Ritu and you did a fantastic job. Thank you so much. Professor Panchanand Das, I think your years and decades of experience as a teacher showed through wonderfully well, especially in those 4 points which you gave us as take-home messages summarizing the entire session. Dr. Nilakshay, I think hats off to you. For every question you had an answer ready. You had really done your homework very well and you thoroughly destroyed all the questions that were being directed to you. Dr. Manisha Saxena ma'am, thank you so much for joining in. You and Dr. Ritu being the youngsters amongst all these stalwarts, I think you both shone well and you showed that the younger generation is ready to carry on the torch and that treatment of RPL in India definitely has an evidence-based future. I'd last like to thank our academic partners for today, Bharat Serums and Vaccines, for giving us the opportunity to conduct this session. And of course, to our academic partners, Science Integra team, TOG, Subbu, Session and Shrimon, thank you so much for all your backbone support and everything that you do to make these academic sessions so fruitful and rewarding, not just for us as faculty, but also for the hundreds of audience who log in every time. Thank you so much. And we hope all of you will stay safe and we will see all of you very soon. Thank you, everyone.
Thank you, Dr. Thambe, and a big thanks to Sarita Bhalera ma'am, who makes us too comfortable in this panel discussion. Thanks to everyone. Best wishes to our own Girija ma'am. We all are with you. We all are with you, ma'am.
Thank you so much, Ritu. Thanks.
Yeah.
And all the very best, Girija, and thank you so much, Pratik. You have really conceived and delivered in a very fantastic way this whole webinar on recurrent pregnancy loss.
Yes.
Thank you.